Good morning and welcome to this meeting of the Health and Adult Social Care Overview and Scrutiny Committee. I'm Councillor Karen Calder, Chair of the committee. I'm obliged to inform you this is a meeting is being live streamed and recorded. Members of the public will be able to hear the audio of the meeting and view the papers shown on the screen. The meeting is held using remote technology, and should any committee members experience technical difficulties during the meeting, they should immediately contact the IT support line on the number they've already been supplied with. Everyone is requested to mute their microphones unless asked to speak. Please only use the chat function to indicate the desire to speak. Do not use it for anything else. As Chair, I will interpret the Council's existing standing orders in light of the requirements of remote participation with advice of the monitoring officer prior to making a ruling. At the start of the meeting, I will ask members of the committee to confirm their presence and any disclosable pecuniary interest they have in light of any of the items on the agenda. I will ask everyone invited to speak during the meeting, including members of the committee and officers, to introduce themselves each time before they speak. Apologies, we have one apology, I believe, Amanda, and that is from Councillor Tracy Huffer.
Yes, that is correct. We haven't received any other apologies or notifications of substitutions.
Thank you, Amanda. So I'm now going to give a roll call. And in this, members are reminded to disclose any pecuniary interest in any matters they have which are going to be discussed, which is not included in the register of interests, and leave the meeting prior to being discussed. I, Councillor Karen Calder, have no interest to declare. Councillor Roy Alcroft.
Present and no interest to declare.
Thank you. Councillor Gerald Aiken. I know he's here. We'll come back to him in a moment. Councillor Kate Halliday.
Thank you, Chair. Yes, I'm present, and I'd like to declare that I work for a professional body of whom We Are With You, which is the Drug and Alcohol Service, is a member.
But that's not a pecuniary interest, is it? Is it a pecuniary interest as you're employed by them? I'm not sure.
Probably just like to declare it anyway, okay, just in case.
Yeah. Okay. Thank you for that, Kate. Councillor Simon Harris.
Present, Chair. Not a pecuniary interest, I don't think, but as usual, I declare that I am a trustee of a care home.
Thank you, Simon. We've had apologies from Councillor Tracy Huffer. Councillor Simon Jones.
Yeah, present, Chair, and no pecuniary interest, but just to state that with regards to item 7, I am the partner governor on MPHE.
Yeah, thank you for that, Simon. Councillor Heather Kidd.
I am certainly present and I have no interest to declare.
Thank you, Heather. Councillor Paul Milner. Apologies for my phone going off in the background. We'll come back to Councillor Paul Milner should he be able to join us later and ask whether he has any pecuniary interest. Councillor Madge Shinton.
Present, Chairman, no interests to declare.
Thank you, Madge. I'm going back to Councillor Gerald Aiken. I know he came in and then left. I don't know what's happened there, but we'll pick that up if he's able to join us later. So other participants in the meeting to confirm their presence. I have David Voisey, Health Watch. Councillor Dean Carroll, portfolio holder for adult social care.
Present, Chair, and no pecuniary interests.
Thank you, Dean. Councillor Rob Gittings, deputy portfolio holder for public health.
Councillor Gittings sends his apologies, he's detained on work.
Okay, thank you. Councillor Lee Chapman, co-chair of Health and Wellbeing Board.
Yes, good morning, Karen, and no pecuniary interest to declare. Thank you.
Thank you, Lee. Yvonne Coleman, service manager, adult services.
Yes, good morning. I'm present, so nothing to declare.
Thank you, Yvonne. Karen Collier, Regulatory Services Operations Manager.
Hello, yes, I'm here.
Thank you, Karen. Welcome. Michelle Davis, Service Manager, Commissioning and Governance.
Hello, Chair. It's Daniel Webb here, Revenue Scrutiny Officer. Just to confirm, I've asked some of the officers not to attend until a little later, so they might not respond.
Oh, wonderful. Okay, so thank you very much for that, Daniel. That makes perfect sense and an excellent use of their time. So I'm just going to run through the names of the people we are expecting. You don't feel as though you don't. Please feel as free that you don't have to respond. I'm just letting people know that you're going to be here. So that means we've got Laura Fisher, Housing Services Manager, Karen Ladd, Early Help Project Manager, Susan Lloyd, Consultant in Public Health, Tanya Miles, Executive Director, Adult Social Care and Housing and Public Health. And then we've also got Councillor Cecilia Motley joining us. I hope she's going to be present. I explained to the committee earlier on that Cecilia, in her scrutiny, has also looked at an element of looked at housing, which of course crosses over into some of the area that we're looking at today in terms of adult mental health. So we've invited her along, and I would hope that members would agree that she can behave and act as though she were part of the committee, and feel free to ask questions that might have occurred or come up in her mind since they previously looked at this particular area. We have Stephen Porter, Interim Assistant Director of Adult Services, Jane Randall, Strategic Commissioner, Substance Misuse, Daniel Webb, Overview and Scrutiny Officer, Rachel Robertson, Director of Public Health, Deborah Webster, Service Manager, Commissioning and Governance, Amanda Hollyoak, our Committee Officer, and then from the NHS we have a number of people who I know have just registered in. We have Kathy Riley, Managing Director, Shropshire, Telford and Wrekin Care Group, Midlands Partner Foundation Trust. Gosh, that's a mouthful. Paul Bowers, Head of Operations, Shropshire, Telford and Wrekin Care Group, Midlands Partnership Foundation Trust, and Colin Evans, Clinical Project Coordinator, Shropshire Clinical Commissioning Group. If you're here, welcome, and I look forward to your participation in this meeting. I've just had a note saying regrettably Councillor Motley's had to give her apologies this morning, but Daniel is as the scrutiny officer with oversight of her committee as well as this committee, I'm sure you'll be able to provide that link as and where you see fit.
Yes, I will, Chair.
Thank you very much. So we now move on to item 3 of the agenda, which is the minutes of the meetings. First of the one held on 9th of November 2020 and the 25th of January 2021. For all of those external members attending this meeting, I'd just like to give an explanation as to this. We've had a backlog of minutes due to resource implications and tragically a death within the committee officers that support this committee. So we have been running slightly behind. So can I move the minutes of the committee meeting held on the 9th of November 2020 and 25th of January 2021 as circulated be signed as a correct record?
I'll second that, Chair.
Thank you. Are there any areas that which members might want to correct or ask questions of? Kate. Councillor Kate Halliday.
Yes, thank you, Chair. It was about some questions that we didn't get answers to, questions that were put by Diane Peacock.
Yes.
To the January meeting, and I think understandably we've just gone into lockdowns. We didn't get answers to them, but they've appeared since. So would it be all right just to raise some issues with those questions?
We're going with that will almost be an item, if you like, under public questions, because we're covering the old questions and Diane has submitted more. So if it's okay with you, Kate, and also with you, Daniel, as you're the one covering this, we'll deal with that then.
Yes, thank you. Thank
you, Kate. So are there any other members who would like to raise any issues on those 2 sets of minutes? I'm not seeing anything on the chat nor hands going up, so I will accept these minutes are a true record and and will sign them. Thank you. We now move on to that particular area, which is public questions. Daniel, I'm going to hand over to you. We have, I think all members will have seen attached to the papers that there are the answers to Diane's original questions, but we also have questions from a couple of questions from Diane, and also from a gentleman called Mr. Ian Barber. Daniel.
Good morning, Chair. Hello, Daniel Webb here, Overview and Scrutiny Officer. I'll be reading out the questions and the answers from both submissions this morning. Could you just confirm the name of the first person again, please? IB, Chair?
Ian Barber.
Ian Barber, okay. I have. Thank you for that. Sorry, Chair, I'm operating on several screens here at the same time. Okay, we have 3 questions here. Question 1, what proportion of total payments made by the Council for domiciliary care are to small and medium-sized businesses based in Shropshire? And the answer is as follows. In order to answer this question to the satisfaction of the individual seeking information, we would need to request some further details, as set out in the report in regards to domiciliary care that was submitted to the committee in January. 75% of the domiciliary care companies that we work with are small to medium enterprises. However, in order to satisfactorily set out the proportion of payments made by the Council, we will need to look at each individual provider, the size of the company, and the amount of money that they have been given, which will take some time. Also, in order to achieve this, we would require the following information. What time frame or snapshot period of payments is being inquired about? The number of people who are supported by different organisations changes on a daily basis, so a specific time frame would be required. Which payments are being referred to for this question? The Council pay for care packages to providers, and there are a number of categories of domiciliary care, such as living care, nighttime care, reablement, and so on. But we have also been making payments for grants to support COVID, and there are a number of different grants which have been made in the previous 12 months. Please could this specific category of payment be defined? This is not part of the written answer, but just to confirm to the committee that I will forward this on to the person asking the questions to seek that further information. So we will keep this thread going.
Thank you. Could you also supply those responses to the committee, Daniel, so that they can absorb those responses to the questions and keep it in mind?
Yes, I will, Chair.
Thank you.
Of course, Chair. And these will also be published along with the minutes as well on the website in due course. Question 2. The Health Watch Shropshire report referred to in the overview found that continuity of care was an issue, with 24% of responders saying they see too many carers. What further consideration has been given to requiring providers to improve performance in this area? And is there any evidence that the issue has been successfully addressed? The answer is as follows. We have shared these observations with providers, and they are in agreement that less carers mean better continuity. Some of the work we are doing has been impacted by the pandemic, so we are looking to move forward with this now and working with our provider market to embed better practices where we need to. We will also be asking our monitoring officers to look at this issue when they go to visit domiciliary care providers to see if improvements have been made for providers who struggled with this. Question 3. Though I do not require the committee to address this point, I have been unable to find the CQC Home Care Survey of 30th of November 2020 as referenced in the report. When I contacted the Care Quality Commission, it replied that it could not locate any such survey published on that date and that it no longer carries out the Home Care Survey. I would be grateful for further guidance on this. And the answer is we will respond to the issue directly to the inquirer with the survey used. And those are the end of those questions, Chair.
Thank you. And could that link also be provided for members of the committee as well?
Will do, Chair.
Thank you.
Shall I move on to Diane Peacock's questions?
Yes, please.
Okay. There are 5 questions here. Question 1. When care home staff and/or residents test positive for COVID-19, do relevant groups within the council receive timely anonymised updates from care homes? Answer is as follows. Yes. When people in care homes test positive for COVID-19, this is reported to Public Health England, who then report to the local public health team in Shropshire. We are then able to ensure we know about all outbreaks. An outbreak is 2 or more people, and that care homes get the right support in regards all the issues they are facing, and we are assured that everything should be in place to protect people is robust. Question B. When care home residents are admitted to hospital, do relevant groups within the council receive timely anonymised data from care home providers? Yes. Any time a care home resident who is ordinarily resident to and or funded by Shropshire Council is admitted to hospital, the care home is required to inform the relevant team in adult social care. The information is specific to the individual and not anonymised. Question C. When patients are discharged from hospital into a care home, do relevant groups within the council receive timely anonymised updates from SATH or Shropshire Clinical Commissioning Group? If not, do care homes provide the council with anonymised updates on admissions from hospital? The answer, yes. When patients are discharged from hospital into a pathway 3 setting, such as a care home, the council receives numerical data from SATH which confirms all of the discharge pathways. Question D. Do the relevant groups within the council receive any anonymised data from SATH on the number of care home residents admitted to hospital for another condition who test negative on admission and then 7 days or more contract nosocomial COVID-19? No, we do not receive data on admissions from care homes from SATH. Final question. How effective does the committee consider COVID-19 data sharing protocols and changes to patient information regulations have been in supporting infection prevention and control in residential care homes in Shropshire? The answer. In terms of COVID, the main mechanism that allows sharing where the purpose is directly COVID related is the Health Service Control of Patient Information Regulations 2002, COPI. This has been extended to the end of September 2021, and a link to this is shared below. We will obviously publish this along with the minutes. And also on the intranet here, there will also be a link there that will be published. The requirements set out is below, providing the processing and sharing is for one of the COVID purposes set out in part 3 of the letter at the link above. 2.1. I hereby provide recipients with notice under Regulation 3 open brackets 4 close brackets that I require you to process confidential patient information, including disseminating to a person or organisations permitted to process confidential patient information, including disseminating to a person or organisation permitted to process confidential information under Regulation 3 open brackets 3 close brackets of COPI. 2.2. Organisations are only required to process such confidential patient information 2.2.1, where the confidential patient information to be processed is required for a COVID-19 purpose and will be processed solely for that COVID-19 purpose in accordance with Regulation 7 of COPI. On this basis, it all depends on the purpose of the sharing, but if it is related to COVID or for one of the COVID purposes, then this gateway allows the sharing with health partners and is effective. And that ends the answer.
Thank you. Kate, you said you wanted to ask a question on this particular area. Would you like to come in now? Councillor Kate Halliday.
Thank you, Chair. It was actually for the questions that were from the previous meeting. Is that okay?
That's fine.
Yeah. I think it was around, there was an answer to question 4, how many patients with a positive test for COVID-19 have been admitted to and or discharged from hospital to any of Shropshire care homes since the beginning of September 2020. And I'm just aware this is kind of specifically about care homes. The answer basically, and please correct me if I'm wrong, Daniel, I'm not going to read it the whole answer out, but I think it basically said no one was discharged. However, they couldn't guarantee that and that everyone had had a test. However, it might have been that they were still incubating COVID and may have tested positive once they got home. Does that sound about right to you, Daniel?
I must point out these aren't my answers as such. I
Okay.
really forward these on.
I suppose it was just there have been a number of suggestions that people have been being discharged from hospital with COVID, and I guess it was just really a question about how confident we're feeling about some of the data that is being released from the hospital, because there appear to be quite strong suggestions, and I'm not saying it's for care homes in particular, but some sort of strong suggestions that people have been discharged from hospital with COVID without sometimes the carers being aware of it.
Can I just come in on this? And I think maybe this could be something that could go. This is slightly separate from, I think, the areas that Diane Peacock was specifically interested in. This is another area. I think you're suggesting that, or you're talking to people being discharged from hospital back into their own homes with carers. I think, Daniel, with your support, I think this is something that should go maybe onto a future work programme to ask those very specific questions. I don't think that we've got the people here that can answer those questions at this moment, but they have been raised in previous meetings. I've just seen that Heather Kidd wants to speak on this, and I think that she probably wants to cover this. As I say, I think this is probably something that we could you could actually move in the next administrative year or cycle, put onto the work programme.
Could I just quickly reply to that? I mean, I think it's certainly about people returning to carers at home, but I think there's a broader question about the data that we are receiving from staff. Yeah, thank you.
Thank you, Kate. Heather.
That was exactly my point, Karen, that actually we do know that people were being released without the test results until they got home. Yeah. And we need to challenge this data to care homes, because I am quite concerned that actually we might have got the same thing happening there. But whether it's to a care home or to carers in the community, I certainly have instances where carers in the community have suddenly had to deal with people who've been discharged at odd times, and it is a much bigger piece of work that we do need to look at, and I'm still waiting for the hospital to come back with the final piece of work, and I'm about later today to remind them that they owe me quite a lot of comments, and there were 3 bullets for them to come back on, but they certainly have been discharging people without their results or without telling people.
Okay, thank you for that, Heather. I'm just, as you were talking there, I was just thinking that this is probably not wishing to slope shoulders on it, but actually maybe the Joint HOSC might have more teeth in addressing this, and it's something that maybe the Joint HOSC should answer or should take forward in their work programme, because if it's affecting residents of Shropshire, it will also be affecting residents of Telford and Wrekin, and rather than duplicate the work, it's maybe better that it just goes through that one single committee. Tanya, I see that you want to come in.
Thank you, Chair, and that was my suggestion, was to take it through to Joint HOSC, but just to reassure members regarding question 4, there was a very clear process put in place. So for any resident being discharged to a care home, needed to be tested. If they were positive, they would go to one of the COVID designated settings in Shropshire, a dedicated unit to take residents with COVID. If they were negative on that test result, they would be discharged to another care home, but they would need to isolate for 14 days. And we know from very careful monitoring and through CQC and through the CCG doing infection prevention control visits, and that was absolutely happening. So just to confirm, if you were positive, you would be discharged to a designated setting in Shropshire. If you were negative, you would be discharged to the care home, but you would need to self-isolate for 14 days. But I do agree, Chair, that it would be good to take it forward to a Joint HOSC for a future agenda. Thank you.
Thank you. Daniel, could you make sure that goes forward? I mean, I've got one more meeting, I think, with my counterpart tomorrow. I'll raise it then, but as someone who will be there, could you make sure that that goes through, please, Daniel?
Of course I will, Chair.
Thank you. We now move on to, my papers are all over the place now. We now move on to member questions.
Chair, I am back on board now. I did put it on the chat. I don't know
Yes.
if I'm going to be there. I've had trouble all weekend with my internet, so I'll hang on here as long as I can.
Okay, can I just ask you quickly, do you have any pecuniary interest, Gerald?
No, I don't. No.
Thank you very much. That was Councillor Gerald Dakin. So item 5 is member question time. As yet I have no member questions, and my understanding is there are none.
That's correct, Chair.
We now move on to the next item, which is delivering public health outcomes. Welcome, Rachel, to the committee. I suppose just for a quick run-up as to why we've got this here. In 2019, Shropshire Council proposed a new approach to improving public health. Rather than delivering its traditional public health services such as weight management and healthy eating advice, smoking cessation and other similar schemes, it instead decided to embed those functions, if you like, and embed the public service funding in all areas of the council. This approach was endorsed by a full council in February 2020. There was a degree of cynicism around the approach that was taken, and officers pushed back quite rightly and actually commended the way of working forward. However, the committee decided that it would like to track particularly the substitutions that were made and the memorandums of understanding. There was, and Daniel's pointed this out, a commitment to have a task and finish group to track this work going forward, but of course COVID has overtaken all of that, and not being a great fan of task and finish groups, that seems to have fallen by the wayside. So Rachel, if you would just like to present your report. Thank you for the report. It's a comprehensive report. I don't know if Susan Lloyd is also contributing as well, but if you please like to present your report, and then we can ask questions or would you like to take questions as we go? It's entirely up to you.
So no, thank you, Chair. So I was going to just give a bit of an overview of the report, and then I've got some colleagues on the call who will be talking through some of the detail, which I think the committee were very keen when we last met, that you kind of saw the detail and understood the impact of some of the actual work that had been undertaken. So colleagues will then talk through a presentation, and then we'll hand back over for any questions that colleagues may have, if that's okay, Chair. Okay, so I mean, thank you, Chair, and you've given, as you said, I'm assuming that everybody's read the report and the appendixes that are attached, but I just wanted to give a kind of high-level summary of the report before I hand over to colleagues. So as Chair, as you've pointed out, this is a new approach, and if you remember back at the committee 18 months ago, 2 years ago, we discussed the public health outcomes, the approach to improving public health outcomes, and the importance of improving public health outcomes across 4 domains. So the fact that if you want to deliver improved population health, which is what we're all about, and public health outcomes, you need to take an approach that is across not only lifestyles, but also across integrated care, across communities, and of course wider determinants of health, which are particularly important to people's health outcomes. The substitution is one of the approaches. So we across public health, so we still do fund services in both lifestyle, in healthcare, but we have taken an approach, and substitutions alongside our health in all policy was a way of embedding public health outcomes across the wider council. Health in all is an approach that was approved by the council back in February 2020, and having a health in all in everything we do in the council, having an approach that considered the impact of health and improving health outcomes. But substitutions, if you like, is an additional layering that gave that boost to areas where we thought that public health outcomes needed further delivery in Shropshire were a priority, and it was to give those areas to more additional work to deliver public health outcomes. Now, you'll see from the range of papers and the range of areas that we substitute that we've taken a broad approach, that we've done that from children's which obviously children's health is particularly important, across to areas around vulnerable groups, homelessness and domestic violence. And then, of course, and as we've seen in the last year, health protection and emergency planning are a significant part of delivering improved public health outcomes. What we've put in place is a very robust process and very rigorous to understand that those are being met, that we're monitoring our outcomes. We put agreements in place so that we can be assured, that colleagues can be assured, members, but also obviously Public Health England need to be assured that we're spending our grant in the most appropriate way across that breadth of public health delivery. So I wanted to put that within that context. Of course, you've already pointed out, Chair, that this has been a particularly challenging year since we last came to the committee, and that has had an impact on the report in both collecting and monitoring of outcomes. We have, as you'll have seen, some of our outcomes have been skewed, but I hope members would agree that we have certainly this year been focused more than ever on delivering public health outcomes, albeit not perhaps the way that we initially planned to start if you'd asked us 18 months ago. It also has actually seen a complete change in the approach and actually a catalyst in rapidly moving forward the approach to understanding public health outcomes, understanding the importance of health in everything we do. And we've seen a significant shift across the country, but obviously we're talking here particularly within the council, and actually some of that's very difficult to capture, but actually that is there. There's certainly, I've seen a shift in awareness, and we can talk about that after this report. And I think the final comment I'd want to make is obviously that we will and we do continue to review everything that is in here. We will review within that context of COVID, living with COVID, those bigger health impacts where we need to be putting our resources. This is a constant process of review and of tweaking and making sure that we get this right. We're absolutely committed to doing that and making sure we use our resources in absolutely the right way. So that's just a high-level overview of where we are and what I hope the paper brings to life. What I'm going to do, and I think the committee were very keen that you didn't just hear from me and you didn't just read the report, but actually we got some of our colleagues, and I'm going to hand over some of those now to really hear how we've used some of this resource and how we've delivered some of those public health outcomes and the impact that this has had on the services that they've been delivering in public health outcomes. I'm going to hand over to Laura first of all to talk about some of the housing work, and then we'll hand over then to Karen Collier to talk about regulatory services work, early years, and then to emergency planning. So I'll stop talking if that's okay, Chair.
Thank you very much, Rachel. So welcome, Laura.
Good morning, everybody. Thank you very much. So I'm Laura Fisher. I'm Service Manager for Housing and Occupational Therapy at Shropshire Council. Sue, if you could go to the next slide, please.
Yes, I will do, Laura. Just picking that up. I might need to disconnect and come back in. I apologise.
Just to sort of so members are aware, we're having slight techie problems, but just bear with us, and we'll I say confidently we will sort it out, yes, or we'll talk through it.
I will be with you in 1 minute, Chair. I apologise.
No, that's fine, Susan. Thank you. There we are.
Brilliant. Daniel, are you sharing
Chair.
now?
I have it shared, Chair. Daniel Webb, Overview Scrutiny Officer.
Thank you, Daniel.
Great stuff. OK, thanks, everybody. So to start off with, we've just got a couple of case studies just to kind of demonstrate the multi-agency working that goes on around homelessness and rough sleeping. So very briefly, really, the first individual that we were talking about, so young man in his 20s, presented with a number of issues, all relating to his alcohol addiction. So he was homeless due to a number of behavioural issues. So again, that will have been down to his alcohol addiction and the behaviour that he then demonstrated once he was under the influence. Looking at the possible outcomes that we had was around full discharge by the housing team. So that means that he was at risk of rough sleeping, that the local authority wouldn't have a duty to accommodate long term, simply because of the behaviour that he was demonstrating in some of that temporary accommodation that we had provided. But further to that, there was also a risk of organ failure and death. So working in partnership with a number of different teams, but notably the mental health social work team and Shropshire Recovery Partnership, the homeless team worked to engage the individual to the point that he accepted detox services. And I'm really pleased to say that 9 months on, the individual is now alcohol free. He opted to relocate out of the county as part of his recovery, currently enrolled in a course which will lead to a professional qualification, which is actually looking at assisting people that will find themselves in a similar situation to him. So I think we can all, be very aware that is a positive outcome, 100%, and it just shows working together, as a number of different teams, actually what we can achieve. So Daniel, if we could go to the next one, please. So again, another individual that was working with the housing options team, the homeless team, but also with a number of other services as well. He was in prison due to be released, and we were aware of a number of different mental health concerns that the individual portrayed. He was assessed by a psychiatrist as needing support, and also that he would actually find living with other people challenging. A lot of our temporary accommodation can be shared accommodation, so that instantly can cause not issues, but things for us to consider when somebody is being discharged or released. So the worst possible outcome was that the client would be released from prison, NFA, and become homeless immediately. So in effect, would become a rough sleeper. So working in partnership, and you can see the number of agencies that were involved there. Housing Options were able to gather the relevant paperwork that we needed to be able to undertake that homeless application, and to ensure that we were able to put the correct support and accommodation in place for that individual. So when he was released, a support plan was put in place. The client was released into self-contained accommodation, which was so important to what he needed, and he's currently going through that homelessness application. So he's an ongoing case for us. But it just, although paperwork might seem quite minimal, actually it's important for various services to better understand individuals so that we can properly support them, and that multi-agency working allowed us to do that. If we could go to the next slide, please, Daniel. So just some facts and figures in regard to homelessness. So for the financial year 2020-21, so we had 636 people accommodated due to being in housing need. We actually have approximately every year over 3,000 people come through the door, but this was individuals that had a duty to be accommodated by the local authority. Of those, 67 individuals were known to have previously rough slept at some point. 293 households had their homelessness prevented. So what that means is that actually we were able to resolve their homelessness before we got to the point that the council had to provide accommodation. We were able to put that support in and assist them early. But we also had 907 households who had their homelessness relieved. So all of those individuals would have either been in our accommodation or would have been considered homeless at home. But in effect, we were able to assist them into alternative accommodation before the council accepted a full homeless duty. And these are some of the changes that came in with the Homeless Reduction Act. So we have that element of prevention and that element of relief and the days in between. And then I thought it was just important to focus on the key areas of work for us over the next 12 months. So we're looking at reducing our use of bed and breakfast. We completely recognise that for someone's health and wellbeing, bed and breakfast is not suitable accommodation, and therefore we're looking to increase our council stock and our access to more suitable temporary accommodation options. We're also looking at increasing the number of households who've had their homelessness prevented, so basically picking them up as soon as possible, putting in place that support and those resources to assist as soon as possible. And also continuing to work to reduce the number of rough sleepers in Shropshire. So when I submitted this slide, that was sitting at 4. I'm pleased to say that actually as of today, that's sitting as 1. But those numbers are fairly fluid. So by tomorrow, that might change again. But I think it just shows that that's our ongoing work at the moment. They're our focus in regard to the homeless team. If we can go to the next slide. So this is just picking up on the domestic abuse side of things. So I don't profess to go through all the different facts and figures that are in this presentation. You can clearly see them, but it was just to give you an overview of the number of referrals that actually come into the service. So you can see, H&ASC, which is the Shropshire Domestic Abuse Service, you can see that there's over 900, nearly 1,000 referrals come into that service on a yearly basis. primarily females, but actually a large number of males also come through the service, and H&ASC provides support to both genders. It's useful to just look at where the referrals have gone to, so you can see that a large percentage is the outreach work, so that's when individuals are able to remain in their property, so that might be with support from the sanctuary scheme, or actually we place in temporary accommodation and we work with H&ASC in regard to that. So refuge accommodation isn't the only option that is available for people, and actually having that outreach support enables to give that support while they're out in the community rather than having to come into that refuge setting. It's also relevant to say that the majority of referrals come from the individuals themselves. So a number of agencies obviously refer in as well, and will support individuals to do that. But I think that shows the trust and the faith that individuals have got in the H&ASC service, and that actually, a large number of those referrals come in directly to H&ASC from the individual themselves. And then also just looking at the service info. So obviously not everybody that comes through to the service will then engage, but a number of individuals come through for accommodation based support or for group support, outreach, like I said before. And again, just looking at additional support needs. So these aren't individuals that are coming through with domestic abuse solely. You know, a large number of them will also have drug and alcohol issues, mental health. So again, it comes back to that multi-agency working. So that's just a bit of a summary about domestic abuse. I'm happy to take any questions on homelessness or domestic abuse unless we're waiting to the end of the presentation.
No, Laura, I think because each of the presentations I'm imagining are going to be equally as in-depth, so we'll take questions as and after each of the presentations. I just have a couple of quick questions before I open it up to members. And that's, how many are ex-servicemen? I mean, you will ask the question, won't you, have you served? And I'm just wondering what the figures were like for ex-servicemen being on the housing or the homelessness list. And then also this H&ASC is really interesting to me because I haven't come across it before. Okay. My only, obviously I'm sort of slightly older and been around a lot longer, but I was there when Marek was first set up. Is Marek still in existence? Does this sit alongside Marek? Does it feed into Marek? Does Marek feed into this, or can you give me a little bit of a background to it?
Yeah, so just to clarify, we absolutely do have those figures on ex-servicemen. I haven't got that to hand at the moment, but I can provide the committee with that information at a later date. In regard to H&ASC and Marek, so they're intertwined really. So Marek is the police-led multi-agency group that meets to discuss cases in regard to domestic abuse. H&ASC will feed into that. So whether that's referring people into that service, whether it's picking up the referrals from there, whether it's supporting the individuals that are discussed at that Marek. So they're intertwined, they're both available. I think what might be of interest to the committee, and maybe something for a future meeting, is that actually we've got the domestic abuse bill going through the Commons at the moment. So there's some significant changes that will be implemented, and actually additional responsibilities for the local authority. So if the committee is interested, and hope I'm not speaking out of turn by offering, it might be useful to actually bring that as a future agenda item. So once we have a date for that to be implemented, actually I'm quite happy to come and present and go through domestic abuse and some of those changes in more detail.
I think that is certainly, I mean, you know, obviously I can't say, but for my personal perspective, I think that would be very, very welcome, especially as you say, there is new legislation going through, and understanding, you know, what are the expectations that will be placed on the local authority in terms of service delivery, I think would be welcomed. I mean, I don't know where we are in terms of our domestic abuse policy. I always felt it was a bit like Groundhog Day. It was, you know, it hadn't really moved on. I've always been slightly critical of it. So I think it is something that I would hope that in the future, again, Daniel, note to you, note to self, you know, just keep this in mind and take it forward, because, you know, I always think this is an area that impacts in so many different ways, you know, across, you know, mental health outcomes, childhood expectations, you know, ACE, I can never remember what that stands for, adverse childhood what's the
experiences?
Experiences, thank you.
Okay.
You know, it is just so high. It should be so high on our view that we need to keep a close eye on it. So yes, I would definitely ask for that to go forward. I'm looking to see if there are any other members who have questions, particularly around housing.
I have, Madam Chairman.
Who's that?
David Voisey here.
David Voisey, he's our Health Watch representative. Please go ahead, David.
I'm sorry, I'm a bit ignorant. I couldn't find chat to save die chat. That's why I put my hand up.
Oh, that's okay.
I'm just a bit surprised that, if I've got it right, that you've only got 4 people or even less who are sleeping rough in Shropshire. How do you arrive at this figure? I would have thought it'd been a lot higher than that.
I'll be honest, because of the amount of work that we've put in over the last 12 months. So we have weekly operational meetings where we discuss amongst a number of agencies who is out. And we also have monthly managers meetings where we discuss more strategically if there are individuals that are maybe being a little bit more difficult to accommodate. Actually, over the past 12 months, we've had periods of time where we've had 0 people that we are aware that are out in Shropshire, and a lot of it is down to the Everyone In and the Protect programme that the government have brought in because of COVID, because actually that gave us a very clear steer that everybody was expected to be in, and it's enabled us to work with individuals that otherwise maybe wouldn't have engaged with us. And I think lockdown, I'm not saying COVID's been positive, but if we want to take a positive out of COVID, is that actually a number of our rough sleepers we now know intimately. You know, we work with them on a daily basis. They're doing really well. They have a future to plan for, and that isn't a conversation that we would have had pre-COVID.
Thank you.
Councillor Heather Kidd.
Yes, thank you. And I do hugely appreciate the work that has been done during COVID, because I think that is a real bonus. I am still concerned that we won't have the funding to carry on putting them into housing. And I'm particularly interested in housing of people who, with mental illness, who are not able to live with other people, but from rural areas, because frequently the council only finds them somewhere in much more built up areas. And sometimes the communities they come from are more sympathetic, sometimes they're not. But it's to put somebody who is quite rural with significant rural health issues, and I've had one here who was been sleeping rough all over the place in tents and so on in the past, not during COVID, interestingly, but actually trying to find housing and supported housing for that individual where he couldn't go into shared accommodation was very, very difficult. So I'd just like to see the rural aspect of that housing of mentally ill people.
No, and I absolutely agree with you, Councillor Kidd. The council have been very clear that actually one of the top priorities is about reducing our use of bed and breakfast, and actually having responsibility, having access to more suitable accommodation. So we are looking specifically around accommodation that's got that is suitable for people that have got mental health concerns. So it might be that there is more support available there than there would be elsewhere, enabling us to take on individual units exactly for that reason when individuals need to be housed on their own for a variety of reasons. I think ideally I'd love to have somewhere in every single aspect and corner of Shropshire. I think we need to be realistic in that, but I absolutely take on board that, you know, if we know of an individual and actually they need to stay in that area, we will do our best, even if in the short term they have to go elsewhere, that actually we will always look to try and move them back. So if that's liaising with our social landlords, for example, and taking on, you know, vacant properties that come up in that area. So this is a key focus for the council, and absolutely something that we're looking at and looking to improve and continue with ongoing.
Thank you, Laura. Councillor Gerald Dakin.
Thank you, Chair. We have an obligation to house ex-army or forces personnel. Do we have any obligations to look after their wives if there's a divorce or something in the proceedings?
So you're going to need to bear with me. There is some new legislation that's come in around partners of ex-servicemen. So if it's okay with you, Councillor Dakin, I'll clarify exactly what that is and I'll come back to you at a later date.
I'd be very grateful for that. Thank you.
That's fine.
Thank you. Interesting question, Gerald. Kate Halliday, Councillor Kate Halliday.
Thank you, Chair. And I'd just like to echo Councillor Kidd's sentiments on what a good job the council have been doing in housing and everyone in terms of reducing homelessness. And it obviously has had a big impact on individuals' lives, but also their family and the community as well. You know, nobody likes to see people homeless. It was just a follow on, just in terms of, you know, you've obviously had quite a lot of funding. This funding, it will be coming to an end at some point. How confident are you that we'll be able to continue to provide this support? And is there anything that we need to be doing to really ensure we can carry on supporting the homeless community as well as has happened over the last year?
So the funding that we've had so far has come from the general COVID fund that has come through to the council. So there's not specific funding available for this. I think it's important to note that we've anybody that we've accommodated, we've taken a homeless application for, so therefore we've got a duty to continue to accommodate them. The numbers have increased as to the number of people that are coming through, so that is a pressure on the local authority. But actually looking at alternative temporary accommodation, you know, relying further on our social housing partners, you know, Star as our Almo, for example, that will all help to enable us to not only provide better accommodation, but actually in a more cost-effective manner. So this is a piece of work that's ongoing as well.
Thank you.
Sorry, I went on mute because my dog was joining in. Rachel Robinson, you wanted to speak.
Thank you. I'm trying to get off mute. I'm not sure.
You're off. No, you're on again.
Anymore? Am I off?
You're on. Yeah, you're off.
You're off. Right. Just leave it alone. Sorry. Yeah, it was on the comment around funding. So just in the way that we've recognised the impact of health and the impact that COVID has as public health, we've been talking about across a range of areas. With the money that we've had from the government for COVID, so the COVID Outbreak Management Fund, we have used some of that to target vulnerable communities. We'll be looking at that going forward. So we continue with this approach moving forward as we've done through the substitutions. We'll continue that going forward, and where particular communities continue to be affected, we will do that. So homeless communities, one of those. Domestic violence is another area that we've put additional funding into this year. So the public health grant and substitutions is one part of the work we're doing, but we continue with that approach going forward, recognising the impact and the health outcomes of it. It's kind of the reverse, actually, isn't it? It's not in this case, COVID's exacerbated some of this, and we need to address that. So we'll continue that approach going forward and working with colleagues across the council and beyond.
So is that more of an approach to sort of, if you like, I don't want to use an old and jaded word, but mainstreaming the funding for these areas by being slightly more flexible in terms of substituted services? And moving that funding to where it's most needed. Is that sort of the way forward? I
think what we're trying to say is we're constantly looking at this in terms of needs and reassessing and using whatever funding is available based on where the needs are the greatest, and we've continued to do that, and we'll do that. We've got this programme at the moment, but we'll continue to do that going forward. So as new needs or exasperated needs arise, as they have done here, we'll continue to review everything we need to, whether that be children and young people, whether that be homelessness, whether it be mental health is obviously a huge issue, and we have invested in some of those areas where we're completely need led. So I think that's what I'm trying to say. This is constantly evolving, and we need to make sure we put our resources where we need those in the most holistic way that we can.
Thank you for that, Rachel. Is it Karen Collier who's on next?
It is, yes.
Thank you very much. Thank you, Laura. As always, your contribution is always well received, and thank you for the work that you've done in the past, and I know you'll continue to do it into the future. So Karen Collier, Regulatory Services Operations Manager.
Thank you very much. Normally, the public health substitutions would support our work to protect the food chain. So you'd be familiar with the food visits and inspections that we carry out so that food businesses provide safe food to their customers. Over the last year, we've had to provide a flexible response to both the demands of COVID and our usual high-risk statutory duties. I wanted to highlight the public health role of regulatory services and in particular the environmental health professionals during the last year through a couple of examples. So firstly, protecting the food chain. If you think back to this time last year, at the start of the pandemic, many food businesses had to close or change the way they were operating to continue to trade. So they had to move to takeaways or deliveries only. And those business restrictions that were put in place to control the spread of COVID, you know, it had to be dealt with slightly different with our essential food businesses because they did need to continue to trade. So it was a priority for us to ensure that that food chain was maintained and it was safe. There were also lots of concerns about vulnerable people who couldn't access food delivery. So we had lots of voluntary groups, community groups setting up that were trying to provide food to those vulnerable members in their locality. The real risk was that where you've got people that don't normally provide food on that commercial basis or businesses that are diversifying, that those massive changes in the way that they're producing food can introduce new risks. So if normally you provide food within the business premises and then you're going to deliver the food, there's so many risks that they introduce then in terms of are they delivering the meals hot? How long does it take to deliver the food? What's the customer going to do with it then? Are they going to eat the food straight away? Are they going to store it? Can they reheat it? And each of those points introduce further risks, which have got a real opportunity for food poisoning outbreaks to present then, which could cause all sorts of additional pressures within the health system and be a further risk for vulnerable people. You know, it was a mix that we didn't want to happen at that time. So we supported our businesses, but also those community groups to make sure that they had the advice that they needed so they could continue to provide food, but they could do it safely. And in terms of the safe aspect, it was to make sure that the food was safe, but also that the COVID risks were controlled so that the workforce in those settings were safe at work, so that service could continue, and also that those people that were going out into the community delivering weren't presenting a risk of transmitting the virus as well. So there was a huge range of work that we did, and we also worked with colleagues across the council to provide a business toolkit. We've provided business friendly relevant advice on our website and also supported through webinars as well. The second aspect that I was going to talk to you about was in terms of our COVID outbreak management in workplaces. Environmental health officers are skilled in infectious disease control, and that's, you know, in normal times more usually focused around food poisoning outbreaks or Legionella, but those skills have been transferable to tackling COVID. At the start of the pandemic, we offered support to the Director of Public Health and our public health colleagues and identified 4 officers as a dedicated resource to work within the Council's COVID Health Protection Cell, as well as the wider support of our the regulatory services team as a whole. Officers in the team are also responsible for health and safety enforcement in many of our Shropshire businesses, and therefore that COVID secure regulation fell to us, building on our risk assessment approach. So those 2 aspects of our health and safety role and our infectious disease skills meant that we were really well placed to assist with COVID outbreaks in workplaces. And you know, just touching on a couple of examples of work that we've done in the last year, I've put 2 photos there, one being a food processing plant there was a lot of coverage in the national press about potential risks in those workplaces because of lack of ventilation, just the numbers of people and that environment. And that sector is actually regulated by the Health and Safety Executive rather than ourselves. But with our public health role, we were able to do some proactive work. So we did work in partnership with the Health and Safety Executive and our colleagues in economic growth. But we also proactively contacted 38 of our manufacturing plants within Shropshire, who have a workforce of about 5,000, to advise them on the COVID secure measures and really try and get ahead of the curve so that we could do as much prevention as possible. And what we were doing is that where we were identifying common risks, whether it was things in Shropshire or nationally, so particularly issues around ventilation, about risks where people were going on breaks and not necessarily being as COVID secure at break time as they were on shift time, and also about the community transmission, is that we were sharing those findings with key people so that we could try and further reduce the risks. And then I've put the photo of, sorry, if you go back a slide, sorry. The photo of the barbers on, because that can seem like a lower risk setting as opposed to those factories, manufacturing plants. But hidden within those smaller settings where you've got those close contact services is a high throughput of members of the public. So within a couple of days, you can easily mount up close contacts in the hundreds. And so the risks there are as significant in terms of our local population. So again, the work that the team does in terms of following up any positive cases and contacts, and again about sharing that best practice. So similar things again about breakout times, really being a risky point for businesses, and proactively sharing that business advice with relevant sectors so that they can do as much prevention as possible. If you could swap to the next slide, please.
Can I just come in and just ask how many more slides you have? I'm acutely aware of the timing of this and also the importance of it, but this is a 2-hour meeting. I wasn't really expecting all of these presentations, and so if you do have many more slides, Karen, can I just ask that you touch upon them lightly and then we can go into questions from the members?
Yeah, I am just at the very end of mine, actually. So
thank you.
I was going to say that just in terms of performance indicators, that I have provided some there. But I just wanted to make the general point that behind those figures, it's just really to highlight the professionalism and the care and the commitment to public health from each and every member of the regulatory services team. I do have so many examples, and I know that we're short for time and I haven't gone on to those. And I can provide further clarity on any of the performance indicators if you wish. But yeah, that was the planned end of mine. Thank you.
I'm sorry, I didn't mean to interrupt.
No, that's okay.
In any way, but as I say, we do have another item on the agenda, and I want to give that a fair run. I mean, I suppose one of the areas that we were looking at and we wanted assurance about was around the MOUs and the the substitutions. How were they being monitored? There's lots of questions around, what services have been lost, have been cut to affect these substitutions. How are you monitoring the impacts of those services that have effectively been cut or reduced or put into a different way? I mean, some of those services, around obesity, smoking cessation, those can't be measured just in annual performances or annual, reviews. Those are generational issues. You're not going to see the impact of those for maybe a generation. So I'm just wondering how Shropshire is going to monitor some of those longer term impacts, if you like, of this change of services. Rachel, how many more presentations have we got and who are they by?
Am I off mute? Am I off
yes.
Mute? Yes, sorry. So there was 2 more presentations, one from Karen Cadd, who was going to talk about children and young people, and then we had a further presentation on emergency planning from Sherry. So I'm happy to pick up the other points that you've mentioned. It was just what we were trying to do with the presentations is to give you the breadth, and as Karen said, we could talk forever about some of the work you know, and the really good work that's been done to address public health outcomes across the whole organisation, and particularly in some of the substitutions. So there is a couple more slides, if you would want to hear those, or do you want me to address some of the points that you've raised?
I think, you know, with no disrespect to those officers that have prepared presentations going forward, I think I really do need to sort of just try and open this out to the members to ask questions. If you can address some of those points that I've raised, and then we'll go into questions from the members. And I'm just seeing from Tanya, she really wants to cover the early help slides. So yes, okay, we'll do that. If you can cover some of the areas that some of the questions that I've raised so far, Rachel, and then we'll go into the early help slides. As I say, there's a number of questions that have already been raised or have been raised outside of these presentations that I really do want to get onto. So Rachel, and then who's doing the early help? Karen Ladd.
So just to, I mean, I think I wanted to pick up specifically on the point I think you've made about lifestyle services as Chair. So I think we said at the start that obviously what we're trying to do is influence across a range of domains, because that's where we get the biggest output. So not just healthcare, but also lifestyle is obviously an important domain, as are the wider determinants of health, which is where we are with the substitutions. In terms of lifestyle, we still do invest in lifestyle services. So our alcohol services, we still invest in, and actually putting more investment into. We have put investment into mental health. It's been outside of public health funds, grant funding this year. It's been through additional funds from the wider council, but also additional resources we've brought in. So it isn't just that resource, we've looked more widely, and that's absolutely part of what we're trying to do. Everybody recognising their role. The smoking and pregnancy work, we've managed to bring that to a conclusion. We've now got a new integrated service that will be starting later in the year, and that is allowing us to invest some resources in other services. So you've mentioned health, weight, and you've mentioned smoking. They have never been off our minds. What we did originally was need to look at the way that those services were being delivered. We have got that as a priority. The Health and Wellbeing Board and the Integrated Care System have agreed it as a priority. It has been on our minds throughout this. What has happened is that hasn't been able to move forward at the pace we wanted in terms of COVID. If I'm being completely honest, that some of that work's been delayed. What we have done is put aside some resources that will be going into that. That has not been spent. It's been ring fenced. It's in as our, and that will be invested because we recognise it was a priority before. We needed to work in a different way. This is a whole systems approach to weight management that we're looking at, and looking at all of the wider determinants, so that active travel as part of that, our built environment, as well as lifestyle services. We do deliver some lifestyle services still. We've continued to invest in social prescribing. The council puts resource in as well as other colleagues, and that does give us some support around that. But I want the committee to be assured that it still remains a priority. We are still doing work around that, but we know we need to do more, and it is a priority that we're working on, and we've got some resources ring fenced to do that work. So to give reassurance that we are still working across lifestyles, some of that is jointly, some of it, so the people investing, which is absolutely what we want to see, and this remains a priority for us going forward. So whilst we're focusing on substitutions here, I just wanted to give that reassurance that we continue to do that, and we continue to look at the future in those services. We are trying to cover the wide remit that will improve our population health and lifestyle as part of that.
I suppose that just one last quick question from me, and then we'll go on to the early help slides. But how are you measuring those outcomes? Are they being delivered? How are you actually measuring them, or how do you anticipate measuring them to see whether it's working or not?
Sorry, you mean in terms of the lifestyle services?
Yeah.
So we'll continue to monitor all of the public health outcomes and the outcomes framework, and keep an eye on what's happening, how things are changing. We've done some significant work to monitor the impacts of COVID, and that has highlighted that, as you'd expect, weight, alcohol, all of the mental health, all of those are being impacted. So we continue to monitor that at a high level, and obviously through our JS&A, which you'll know there's an updated approach that we're taking, and that's been worked through at the moment. We started work around that, so we're monitoring it through all of those processes. And then obviously where we've got specific services in place, so for example social prescribing, or we're looking at exercise on referral, we can monitor through those, specifically through those contracts. But we do monitor at a sort of strategic level, if you like, lifestyle. It's particularly difficult to monitor weight, as you know, because most of it comes from lifestyle surveys, and we do get some from GPs, but we do have that overview, and we continue to keep an eye on it. But it is it has and remains one of our main priorities moving forward.
Yeah, okay, thank you very much for that. Can we now move on to the early help slides? Karen Ladd, welcome.
Yes, thank you. Good morning, everybody. Just to say that my slides have actually been translated incorrectly. So the title actually says early years, but I am actually here to talk about early help. So our early help team supports families with children aged 0 to 19 and up to the age of 25 for our children with special educational needs and disabilities. I appreciate that time is an issue, so I'll be short and snappy to get through this. I have put some facts and figures in there. Obviously, we focused on health. Most of our referrals that come into early help come in predominantly about children. But when we are talking about supporting families within early help, we take a whole family approach, which means that before we start a piece of work with a family, we carry out a whole family assessment. So although a child may have been referred to us with a dominating concern, through our whole family assessment, we are able to understand the concerns of the wider family and the challenges of the wider family, and quite often pick up health concerns and challenges as part of that assessment, which haven't been identified when they come into us as part of the referral. Over the last 12 months, we have worked with 551 families. Typically, we have capacity to support 330 families at any one time. COVID has put a strain on all of our services, and absolutely across children's services that's been reflected. I think we peaked in December with a caseload of 376 families. So we have had to work in quite a different way. We've had to adapt through the last 12 months, and we've done that by RAG rating families, and obviously families where there are particular safeguarding concerns, we have RAG rated as red, and it's those RAG rated at red and amber that have received face-to-face visits, which have happened predominantly in families' gardens or out for walks in parks. Our early help workforce has been very creative in how they have managed to actually physically see families. For our green RAG rated families, a lot of that work has become virtual support, which actually has led to some very interesting success, particularly with our young people who we are supporting, who are not always keen to engage with our workers, but actually are very adept at accessing support virtually. So actually we have seen some greater success engaging with some of our young people during COVID. And certainly we'll be looking at how we deliver our service moving forward as a result of that learning. You can see there in some of the percentages that I've put in are directly related to health outcomes that have come out of our early help assessments. So from April to December, 42% of families open to early help were identified as having domestic violence or parental conflict as a factor at assessment. At the time of their most recent review, 64% had reported an improvement. Actually, only 5% reported getting worse. 31% were coming out as staying the same, and obviously we are still involved and supporting those families and supporting them to engage with other services such as Shropshire Domestic Abuse Service for appropriate levels of support. Between April and December, 95% of families open to early help were identified as having a range of emotional, physical health challenges as a factor at assessment. Now that could have been either the child or the parent. As I've said, we take a whole family approach and offer the support to all family members where it is needed. At the last review of those families, 55% had reported an improvement. 37% had stayed the same, and we are obviously still engaged and supporting those families. 8% had reported getting worse, and that may well have been about a health concern that actually we would expect to escalate or to get worse, unfortunately. The last number that I've put in there is about 77% of families in December open to early help were identified as having a mental health issue or concern. Unfortunately, I can't compare that to previous years because we have changed our monitoring systems this year. So our data quality is actually much improved this year. But the feeling across the early help teams is that is quite significant. The feeling is that we are supporting a lot more children and young people this year during COVID around their mental health and emotional health needs. Would you mind moving on to the next slide? Just a note there about our parenting team. As part of the early help offer, we do have a small parenting team who are supported by funding from public health. Our parenting programmes have continued through COVID. We know that outcomes for families are a lot better if they're supported as groups. They benefit from peer support and learning from each other. The parenting team have worked very creatively to continue to support families. Face-to-face delivery was suspended in March at the beginning of lockdown, but the parenting team continue to deliver individual packets of virtual support for families, and then actually have started delivering virtual groups in November, which have had some success. They are keen to get back on the ground, but at this time they are still delivering some virtual groups. And also work in partnership with other agencies. So one of the groups that they deliver, Me, My Child and Domestic Abuse, they do work creatively and in partnership with Shropshire Domestic Abuse Service to meet capacity around that. The final slides that I've provided, I won't go through with you because I know time is an issue, but I hope that you'll take the time just to read them, because I have provided a case study which just demonstrates some of the work that we do in supporting young people around their emotional health and well-being.
Can I just ask a few questions? Well, there's one. You said that you're supporting more young people now. Now, is that because there are more presenting as a result of COVID, or is it because better working practices, or is it a combination of the two?
I think it's very much a combination of the two. I think certainly during COVID, it has thrown a new pressure across our services, across children's services, early help and children's social care. We've certainly seen numbers rise, and we've almost been able to track those numbers as lockdowns have been put in place and then been lifted. So there's certainly been an influence. But actually, I think our partnership working has very much played a part, because our partner agencies are very aware of families, doing a lot of work to keep in touch with families when they're not in education or not in school because of current circumstances. So we have been getting a lot of referrals in. I think our partners have almost in some instances been overly cautious, which is absolutely the right thing to do. So a combination of the two, really.
Yeah. Okay, I'm just going to open this up now. I'm going to quite literally have to draw a line on this in 5 minutes. I've noticed, Dean, that you want to speak, but can I just ask if there's any other members of the committee that would like to ask questions, and before we can actually just summarise this up. Any other members like to ask specific questions, please? Okay, Dean, you've got 2 minutes, quite literally, and then I'm going to cut you off.
Thank you, Karen. I hope that these presentations have shown committee the real range of services, and when we say health in all services, we actually mean it. The range of services and positive outcomes that have arisen from the substitution programme. It's unfortunate that we are running out of time, but I think it's good that we've done it the way we have, and I think officers have spent a huge amount of time in putting this together, because the last time that we presented an update on the public health substitutions, the feedback from scrutiny was that it was too focused on the dry KPIs and MOUs and SLAs, and you couldn't get a feel for the reality, and you wanted to know more about the actual programs and the work that was being done by the service areas. And I think that that's been our intention, and the officers have done a huge amount of work to bring this presentation together. So I hope that it is shared with members of committee and attached to the minutes, because it does show just a very small flavour. And bear in mind that in a year, in the year of COVID, that there is not a single council service that hasn't been affected in some way, shape or form by the pandemic, and how business as usual just hasn't been possible.
Yeah, I think we're all aware of that, Dean, and I'm sorry to cut you off, but I am going to ask, and it has been requested that these slides are sent out and shared with everybody. I don't quite agree with the point that you're making about some of the dry data that we were receiving before. I think the MOUs are very important, and understanding exactly what these substitutions are about is equally as important. Had we known that these presentations were going to be put forward, I would have actually rearranged the agenda and asked our external presenters who have been with us throughout all of this. I would have put this second on the agenda and had our external presentation come first. So I'm very, very mindful of that. And one of the things that I just want to cover quite quickly, and it's because it's been attached to the reports, and that's an Appendix 4. And I did struggle when I sort of had a conversation with Daniel and with Susan Lloyd about how these are being presented. In all of them, and we've got the examples of 4 in the key performance indicators, the KPIs. No, there are no targets being set in any of the areas that are being covered. And I'm just left scratching my head. Well, why have you got that column there? If you're not setting yourselves any targets, why even have that column there? I mean, I'm not a great fan of targets, but it is something good to aim for, and it does give you a sort of an appreciation of how you are achieving. So I think this is a question again for Rachel to cover. As I say, there are quite a few other areas that I almost think, you know what, I'm going to have to draw a line under this and suggest that it comes back again. And allow it the time and the grace for those officers who have put in the hard work to make their presentations, and allow maybe a new set of eyes to look at it, and maybe they'll look at it in a different way. But Rachel, can you just come back and answer some questions around Appendix 4, please?
Yeah, thanks, Claire. So in terms, I mean, this is a very new process, as I think we're aware. Yeah. We've been developing these and developed very quickly and particularly in the last year in very difficult circumstances. I'm very happy to look at targets. I'm not a huge fan of them. They said, but actually I'm happy to take that away, Chair. And I think we've made a recommendation report that we continue to bring this back to scrutiny. Yeah. We're pleased to have scrutiny's interest in it, and I'd love to describe in much more detail the changes that I've seen over the last 12-18 months, and I think we'd like to capture some of that. So I'd love to bring this back and share that with committee for further discussion. So I'm absolutely happy to pick those up.
Yeah. I think it is. We do appreciate, Rachel. This has been an incredibly difficult time, and that targets are not always appropriate. But if you've got that column there, put something in it, so to speak, and actually just for simple things, I'm just looking at the first one, housing and homelessness, number of staff completing mental health first aid training, and there's no target set, and obviously to date, because of COVID, that has not been, that it's still on 0. But that in itself, just one simple one, would be a good target to have, because obviously you would want to have as many of your staff trained in mental health first aid training. So and that is just one simple and small example. And also I would echo your comments about bringing this back, and I hope, Dean, wherever you are sitting in the next administration, that you would also support it coming back to scrutiny on a regular basis, just to see, because I think there is this longevity, if you like, in some of the data, or the requirement of some of the data coming forward, that you're not going to see improvements or declines in just 1 year. It's maybe going to be in 4 or 5 years you're going to be able to realise the impact, if you like, of some of the decisions that are being taken, and then alter course. But I also appreciate that you are being very flexible and agile in your approach and looking to see where the need is. So that is also noted and appreciated. Are there any other members who would like to ask questions on this really, really important topic and area? Or should I move on to the next item on the agenda?
Just to confirm, Chair, that I'm happy to support it coming back to scrutiny. Always welcome scrutiny's views and thoughts.
Yeah, I think just maybe in one last note, just a little bit of more liaison between the scrutiny chair and what is actually going on the agenda, so that we can adjust the agenda, timetable accordingly. That's not a criticism, it's just a hindsight, I suppose. So can I just thank all the officers who've attended for this item, and members who've attended for this item and contributed. Wish you well for the future. So it's been a pleasure working with you all. Thank you. Can we move on to the next item, please, which is adult mental health? Tanya, I'm putting this up to you now. Are you presenting on this? Welcome, Paul.
Thank you, Chair. So colleagues around the room have contributed to the paper that's been circulated to committee. To kickstart our conversation, Yvonne Coleman will give an overview around mental health services, and then you've got Michelle Davis, who's Commissioner for Mental Health. And then we've got colleagues in the room from our health providers, so very warm welcome to everybody. Thank you. Over to Yvonne.
Thank you.
Thank you, Tanya. Good afternoon, everyone. This presentation slide is just giving you an overview of the report that was submitted, and we're just giving you a summary of what the local authority responsibility is in terms of our statutory responsibility around mental health. The report provides some information around the service model that we deliver. It provides an outline of the working arrangement we have with our partner agents, in particular health and the voluntary sector. It describes some of the challenges that we experience in terms of providing supported living accommodation, and it also outlines some of the actions we are taking moving forward, which Michelle will speak of. The report provides an overview of the new contract and commissioning arrangement. Again, Michelle will pick up on this, and we conclude with some 2 case studies, just evidence some of our really positive outcomes for people with mental health problems that have engaged with the service. Can I just have the next slide? Thank you. So just to give a background, the community mental health social work team covers county-wide service, so it does provide service across the spectrum within Shropshire, and it supports people within the communities and people who are admitted to hospital. Oftentimes, some of the hospital admission are people are brought there under the 136 into a place of safety, and often by the police. So we provide a statutory responsibility with that, in line with the Care Act and under the Mental Health Act, which requires the local authority to provide promote individual well-being, to prevent the needs for care and support through early intervention, to promote integration of care and support with our health partners, and to provide information and advice, to promote diversity and the quality in the provision of service that we deliver. In order for us to really deliver an effective mental health service across Shropshire, the key principles around our model is around partnership working. So we ensure that someone who's engaged with a mental health service, the decision doesn't just lie with social workers, it's with our health colleagues, families. So some of our key partnership is Midland Partnership Foundation Trust, We work in partnership with Children's Service. We also provide an out-of-hours service, which covers the children's services as well. We have the independent and voluntary sector, which has proved very positive and informative for us, in particular during this COVID period. The Shropshire Clinical Commission Group, which we work very strongly with in looking at how we develop and commission service. We work with the police, West Midland Ambulance Service. We also work with Shropshire Recovery Board, partnership which Jane will speak about, and families and carers. And then looking at the presentation from Laura, very big emphasis on our partnership working around housing. Now I'm going to hand over to Michelle, who will talk about the partner arrangement we have in terms of accommodation and how we commission services. Michelle, over to yourself.
Thank you very much, Yvonne, and hiya all. Yeah, I guess before I move on to talk about the accommodation, I think it's really important to pick up on the work we've been doing recently around specialist care commissioning for individuals with mental health needs. As I'm sure you're aware, you know, historically we've had real challenges in able to identify the right care and support for individuals with mental health needs, particularly over the years with the disinvestment in the community mental health team offer of care and support, if you like, with support workers and social inclusion and recovery services that are no longer available. So there has been a lack of resource and availability to look into this until more recently, when I took over the commissioning of mental health support services. Within that, we've worked together to look at how we commission our care and support for individuals with mental health needs, and identified a massive gap, and that spans across how we support them to maintain their homes and their housing, you know, particularly when they are having times of, you know, poor mental health. So we worked really closely with members of the mental health team, our Autism Partnership Board, and then Disability Partnership Board and Mental Health Partnership Board to develop a new process for commissioning care and support. So we are lucky enough now to have 9 providers that we've accredited in Shropshire that are able to specifically support individuals with complex mental health needs to maintain their homes, allow them to live in supported living and receive on the whole 24-hour support. But it also allows us to commission differently for the lower level support that we require for individuals with mental health needs. So that's now up and running as of the beginning of April. So we will now go out and commission those services for those individuals in a bespoke way. The process not only involves what we've already done in terms of evaluating the tenders of the applications from the providers, which included the experts by experience and parents and carers and advocacy organisations co-producing not only the accreditation questions, but also the model answers that we expected to see from providers. So the next stage within that process is for anybody who's got mental health needs, who needs care and support, particularly within supported living, we will be looking to put together 2 additional questions when we go out to the provider market that have been successful already, that specifically emphasises the needs of those specific individuals without any data protection breaches, of course, but so that we can tease out from the providers how they can evidence that they can really support those individuals effectively and robustly. So that's a very new process which we now have available, which will make a huge difference to the support out there that's available to those individuals. We also obviously have our voluntary sector support, and you'll see from the report that although there's not anything specifically commissioned for mental health, we do use those services regularly, particularly the befriending services, which are a huge support to the individuals with mental health needs, and the floating support and housing support that's available through the sustained supported housing contract. Then, of course, we specifically have Voiceability, which is the advocacy organisation for individuals with mental health needs who are on a section in hospital and need that advocacy representation. So that really is important to describe because it feeds into how we then support individuals to live in their own accommodation in the community. So this slide talks about the current offer that Bromford Housing Group provides. So Bromford are one of our registered social landlords in Shropshire that specifically focus on supporting individuals with mental health problems, learning disabilities, autism and acquired brain injury. So as you can see across Shropshire, we've got a number of schemes that Bromford provide and we invest in. In Shrewsbury, we have 2 schemes, Beagle House and Upton Lane. And the way these schemes generally work is that they're 7 or 8 bed individual flats, so everyone has their own tenancy in their flat, and then they have a resource flat within the scheme, and within the resource flat there's staff available Monday to Saturday 9 till 5 to support the individuals with their daily living skills and tenancy needs. So they'll do things like group cookery sessions if they want to, or film afternoons as a group. Rather than impinging on someone's personal space in their own flat, they can join in the activity that's going on in the communal area, and it's an opportunity to socialise and meet people. Some of the schemes provide long-term tenancies, and some of them, specifically, for example, the Willows in Shifnal, provide support shorter-term tenancies with a view to move on into more independent living and less supported living in the future for individuals. In addition to the support that's provided at these schemes, of course, when somebody has more complex needs, we will additionally put in a package of care and support for that individual to wrap around and meet their specific needs. The challenge we have with these schemes is they're really popular, as you can imagine. The referrals into these schemes they're inundated, and we need to move away from the bottleneck. So we've got a bottleneck at the moment of people going into the schemes but not being able to move them on into alternative supported living, which perhaps is less supported from a tenancy perspective, but when someone still needs the level of care and support around them, you know, more intensely. So that's what we're working on now. So those are the schemes that we've got currently that are funded by social care, and some of them have got an element of health funding. There is also a scheme in Shrewsbury called 64 Abbey Foregate, which is 6 flats, and again, very similarly configured, but that's fully health funded, that particular scheme. Next slide, please. Thank you. So in line with improving our care and support that we provide for individuals with mental health problems, we've also been looking much more closely at the data that we have around the individuals that are looking for supported living accommodation in Shropshire who have mental health needs. And we've very recently, very new, it's only been up and running for about a month now, created a property platform, which allows us to capture that data much more specifically than we have done previously. The way this is done is that we've got an accommodation lead that sits in my team who takes referrals for anybody who needs supported living accommodation, and she has what we call a pen picture, which gives all the specific details that we're allowed to share about the individual's needs, and we then put that out to the care providers so that we can get the care commissioned by the right provider. So that pen picture allows us to capture a significant amount of data which we haven't captured specifically before, which is uploaded onto our property platform, which our social care practitioners have access to. And as you can see from the data we have on there currently, we've got 52 individuals that we know of that are currently on the waiting list and being screened for looking for supported living accommodation in Shropshire. I think we've got, I can't see in there now, but I think we've got something like 26 high priority cases. And of those, 13 of those individuals require single service accommodation. And I guess it's really important at this point to say that's why it's so much more complex to commission accommodation for mental health as opposed to learning disabilities, and obviously and autism is more complex as well, because individuals with a learning disability quite often have spent time in residential colleges where they've lived with other people, and when they're coming to the age where they've perhaps finished their residential college placement and they're not doing their studying anymore, as you've probably heard previously about the transition team, we do a piece of work to match the individuals so that they can live together under one, you know, in one property. So, you know, 4 or 5 bed houses across the county. However, we know that for individuals with mental health needs, a lot of them prefer to live on their own in their own flats than have an independent tenancy where they've got access to support, but without living in amongst other people, because that impacts on them when there's a deterioration in their mental health. So I think it's really important for us to recognise that there's a need there for that single service accommodation. As you can see, out of those individuals, 7 would like to live in the Oswestry area, and a further 7 would like to live in Shrewsbury. We find Oswestry quite popular and Shrewsbury quite popular, but also we've got others who are willing to live anywhere in Shropshire because they just want to be out of the situation they're in now, and others where we're looking further into the detail to find out exactly where they want to live. So I can have the next slide, please. So obviously this data really helps us to inform much better than we have been able to previously the developers out there in Shropshire who are interested in developing, you know, accommodation in this market. I'm inundated at the moment with contact from developers who are interested in investing in accommodation of this nature. In fact, I had an email this morning about another one in Oswestry. So we are getting that conversation going now. Another thing we do and use this data for is we work really closely with colleagues in planning and policy, which again is a relatively recent relationship that we've developed, so that we can talk to them about our accommodation needs and they can actually have access to this platform so that they can look at it. So when we get planning applications in, for example, we normally talk them through, but in the meantime they can look on our property platform and say, okay, we've got this planning application for these 12 flats in Market Drayton, let's have a look if there's a need in that area for, you know, supported housing, and go from there. So it's really helpful for us to have this data. When I had a conversation with Karen outside the meeting, I think we recognise that there's more information that we need to put on this platform at the moment in terms of we have got current accommodation status, but it's not easily identifiable at the moment. A lot of what we've got on there still is quite narrative, so it's hard to pull it out and extract it as a data source, but we're working on that. That we've got the current availability, we've got the types of property that are current availability, and that obviously we've got the waiting list and the location required. So we're making a start, but like I said, it's a new platform, so it's really helpful to build on that. And obviously some of the discussions we had as well is about perhaps it would be helpful to understand the history of some of the individuals who are looking for accommodation. So, you know, people who've been in the military, or, you know, people who've got specific needs around post-traumatic stress or anything like that, and particularly where location is key, whether it's rural or urban. So we're still building the platform, but it's been a massive help to us and has made a big difference, particularly in our conversation we've been able to have with developers, because it's a much more robust information set for them to take back to their investment board to say, look, we know Shropshire has got this need in this area and we think it's a sound investment. So to support that, we're currently working on our update to our market position statement, which goes out to the provider market and our developer market. And in that, we're going to include some of this broad information around the need and the numbers, so that we can provide them with more accurate information to support their business models going forward. Thank you. I've probably already said some of this, sorry. So in order to provide us with some assurances around developers and the quality of the developers that we're working with, we do ask them to complete a due diligence form so that we can be assured of their financial security. As you can see, we ask them to state their expected rent levels because they can be quite high, particularly with new developments, and we do kind of steer away from that where we can. Our ideal situation is that we work with our registered social landlords, so we're doing a lot of work with Connexus at the moment and Star Housing, which is fantastic, and any developer who puts forward a housing scheme would need to have a registered social landlord to take on the lease of the accommodation anyway, so our security comes from the registered social landlord. I'm going to stop there because I can see Maggie's got her hand up.
You said somebody's got their hand up. Who's that?
Yeah, I think Madge has got her hand up.
Oh, Madge, okay. Madge, go on in.
I tried to do the chat thing, my dear, but the little thing just kept going round and nothing happened. So
okay. No, come in. If anybody has that problem, please just jump in.
Well, there you go. My concern is, and I hear about the registered housing associations, and I see their. The trouble is, I'm a cynical old lady, so I'll preface whatever I'm going to say with my degree of cynicism. There's obviously some pluses that the housing associations can tick box for at the moment when it comes to the provision of this type of development, whether they're flats or a communal house or whatever. I'm hesitant as to whether a number of these housing associations, and you've mentioned two of them, I won't repeat the name, but you've mentioned two of them already, where I know from their other normal tenants, they're not that good with support. So can I ask, what is the meeting of minds between what we provide as Shropshire Council or the CCG or whoever? Where are we with monitoring what these housing associations are actually providing and what sort of services they say they're going to provide to these tenants who need support. I'm very, very cynical about that. I'm sorry. I'd just like somebody to give me some reassurance on that. Thanks.
Yeah. No, that's okay, Madge. I completely understand that. I'll digress slightly just to give you a bit of context as to why we have to work with the housing associations and we can't work with private landlords, because I haven't explained that. So basically, when somebody has got a mental health need or learning disability or autism, we tend to look for accommodation that's bespoke often, you know, especially if they've got learning disabilities or autism and there's behavioural challenges there. We look to adapt the accommodation, which increases the rent levels. If an individual has a standard housing benefit application, their rent levels are really limited to, I don't know off the top of my head because it's not my area of expertise, but around £97 a week. But the rent levels in some of these schemes are higher than that in order to allow for the adaptations and the specialist nature of the accommodation. Therefore, the individuals who we support in that accommodation have to have exempt accommodation status, which allows us to apply for higher rent levels with housing benefit. And we work closely with housing benefit to do this, to make sure that they're aware of what's coming through and any of those specific needs. The only way an individual can receive exempt accommodation status is if their housing is with a registered social landlord. So any private landlord that was providing accommodation directly, they would not be able to do that. But obviously I appreciate a private landlord wouldn't provide an element of support either. So the support comes through our sustain contract, which is managed by colleagues in housing, and Laura Fisher manages the sustain contract and we support with that. And we have been doing work recently to look at how we monitor that, because it's a big contract with a lot of housing providers within it. With the individuals we're talking about here, they will be individuals who also have quite a robust care and support package around them that's provided through the care provider. So they will do a lot of that because they're probably working with them 24/7 anyway. They'll do a lot of that with them as well. So we monitor that from an adult social care perspective in terms of our contract monitoring, and I have quarterly meetings with our providers and they would let us know if they had any concerns with the housing support providers. But I'm sure Laura would probably tell you that the number of referrals through the sustain contract are huge. So therefore, where we put the care and support in for these individuals, that floating support that we call it, that low level housing support, would be targeted at other individuals that perhaps are on the waiting list and currently aren't getting any, because we're providing a more robust support package for the individuals. You're on mute, Madge, sorry.
Sorry, I keep forgetting to.
That's okay.
Any queries that the tenant might have, of whatever reason, comes through you, the care package, not directly to the housing association, for instance? Yeah. Or how does that work? How does it work in essence?
So if they've got a care and support package in place, that care and support provider would be seeing them probably, you know, at least 4 or 5 times a week. If not, when we're talking about supported intense accommodation, which is really my area of commissioning, they're with them every day. So they would be with them every day. So the individual would raise their concerns with the care provider if they were receiving support through the registered social landlord as well, but they weren't happy with it, or the care provider might recognise it on behalf of the individual, because the individual might not recognise it or have capacity. And they'd raise that with myself, and then Laura and I would discuss that, and we work together to look at how we can adjust the contract for sustain or do things differently to try and improve that.
Thank you very much. That reassures me a bit that we are going to monitor, because, you know, these big organisations, and you've mentioned 2 of them, and I know that there are shortfalls in what sort of service they give to their normal tenants. So I'm more worried about people who need extra support. Thanks very much. Thanks, Kat.
No worries, that's fine. Okay, moving on. Just giving you some examples really of some supported living. These are particularly the Bromford schemes. So this individual was somebody who had schizophrenia and paranoid ideas and had really disengaged from support when he first went into one of the Bromford schemes. but he went into the scheme and he accepted the support. He felt excited about having the opportunity to live in supported living. He received a period of support, and during that time he really enjoyed cooking, so he ran the cookery club, as it says in there, but he also gained voluntary work at a hotel in the kitchen, and he developed lots of new friendships via that hotel, and over a period of 18 months, I think it was, I'd have to check back to the actual report, but it's in the appendix, he moved to a point where he was able to move into his own accommodation supported by Bromford Housing Group. He was somebody who was really quite poorly, as you can see, because he spent 8 years in hospital and, you know, was in 24/7 supported living. That's where you have full on wraparound care all the time until he was ready to move on to this supported living scheme with Bromford. And then I think there's another example there, isn't it? Yeah. So this individual was somebody who was previously homeless, who was able to move into one of the Bromford schemes, and they supported this person to develop their independence. And as part of that, they moved to Normandy Place, this one moved to, and they were from the Leaving Care team, so they were a younger person. They had support to maintain their property, personal care, dealing with post, because they'd not had any of that type of support before. They didn't even have any benefits and couldn't access the internet or anything like that. So they had a lot of support to improve things and to increase their opportunities. They were attending the local job centre to identify, you know, job opportunities and things like that. So lots of support within this for this individual. They applied for funding for a small support package so he could maintain his property. So that's having someone going in daily, supporting with his personal care. He also got supported by Enable and secured a job at Greg's Bakery, which is really fantastic. He also worked with the recovery service around drugs misuse, which leads on to Jane's section in a minute, and he received the specialist support he required to move forward. He engaged really well with the key workers at Normandy Place, and after completing the programme of support, he actually moved into general needs accommodation at the end of that service. So it was a really positive story for this individual. So it just goes to show how it can work. So I will hand over to Jane now.
Can I just ask before you hand over, are there any more questions of Michelle from members and mental health, support for mental health, particularly in housing? Are there any other questions from members? No, okay, go on to Jane, thank you.
Thank you, Michelle. Okay, so I've got the last slot really, which is to talk about the sort of co-occurring existence of drug and alcohol dependency and mental health. So from a substance misuse perspective, when somebody enters treatment, we do a fully comprehensive assessment which looks at both their substance misuse, a range of social factors, as well as their physical and mental health needs. Hopefully everybody's managed to read the report that was circulated in terms of this, but just to sort of recap, in 2019 to 2020, of those new presentations in that year, 64% of those seeking help with alcohol misuse identified with a mental health need, and 62% of people with a drug misuse. When we look at that on paper, and this graph which is on the presentation shows how that is then distributed. So as you can see, the majority of people actually receive that mental health support through their GP, so it's GP managed, with a smaller proportion receiving support through either the community or specialist mental health service. So as I said, on paper, 84% of new presentations for alcohol treatment are receiving some level of support, and 69% of those for drug treatment. I think for me, the question is always, are they receiving the right support? Because we certainly know from feedback from service users, staff and family members, carers and significant others, that quite often they feel that that people need additional support, and obviously as a service we will obviously work with the other services to you know, to get them into the right services if they need them, but of course because of excuse me, sorry, because of the impact of drug and alcohol misuse on people, it also creates other social factors which increase the complexity. So quite often, as Michelle's just alluded to in one of her case studies, you know, we have people that are homeless, we have people involved in criminality, we have people that have got autism as well as substance misuse and other things going on. So quite often what this creates though is a challenge within the services, particularly around engagement, and I think this is what we're trying to grapple at the moment. So from a substance misuse perspective, we over the last few years we've developed a system, because as you can appreciate, you know, we can't keep giving appointments out to people who aren't attending, but we do need to try and engage with people. So we try and ensure that we've done absolutely everything if somebody is not responding to treatment to try and engage them with that treatment. But I think for me, what it means is that sometimes those people that are in the real need, because of their complexities, they sort of fall between the systems, so they sort of bounce around, because not only are they perhaps not responding to you know, substance misuse treatment, they may not also be engaging with their mental health treatment, and so, you know, the situation gets worse and worse. And then of course there are the other issues around that, which are around safeguarding and ensuring that particularly people with care and support needs are getting the help they need. But we certainly know that people with a drug and alcohol dependency are particularly vulnerable as well themselves in terms of safeguarding. So what are we doing? So in terms of, as you're probably all aware, there's the mental health the long-term plan, which is probably coming towards the end now. But there was a number of things that we needed to do. One of those was around the No Wrong Door and Everybody's Business, which is a piece of work that's ongoing. So from a drug and alcohol perspective, and particularly around this co-occurring you know, substance misuse, we've got a task and finish group which is currently looking to agree a pathway of care across the system. We know we've certainly got some really good examples of really good practice and support for people, but we also know that some people fall through the gaps, and so this piece of work is actually getting an agreed pathway of care in terms of how, so it should be consistent, so it shouldn't be down to individual practitioners, it should be very systematic in its approach. And we've got colleagues from the services that are involved in that work, as well as third sector colleagues as well. The other piece of work that's going on is we've got a couple of third sector projects that are going on to support reducing health inequalities. There's a new one that is just about to start within the Oswestry area with a very small piece of funding from NHS, from the Reducing Health Inequalities funding, and there is also the bigger piece of work that's going on with the CCG, and again the co-occurring conditions dual diagnosis is sort of the prominent factor within that. Another piece of work that we're developing with the Shropshire Safeguarding and Community Partnership is around what is known as the blue light approach. And this is certainly working with people who are alcohol dependent, who appear to be treatment resistant, and so therefore quite often are hitting the hospital, A&E departments, maybe mental health services, police services, you know, section 136s, but actually then don't go on to engage in any treatment. So we're just about to start doing that piece of work, as I said, with the Safeguarding Board, and looking at how we can introduce that way of working as part of our response to self-neglect. And just to add to that, I know that we are working with the Safeguarding Board to look at the current practice around self-neglect to include some of the work with drugs and alcohol as well. So that's sort of where we're at the moment. I don't know if anybody's got any questions.
Yes, I have a number of questions. Kate, you go first. I've just seen you put your hand up. Please, you go first.
Thank you, Chair, and thanks, Jane, for your presentation. I, welcome a lot of these initiatives, and it sounds like the right way forward. I know drug and alcohol services have experienced ongoing cuts over the recent years, so it looks like there's some really good suggestions of how to manage things within those. I was just wondering, I mean, it can be very difficult to get mental health services and substance misuse services working together, and in particular there can sometimes be barriers to people entering mental health services with requirements of people either being drug free or alcohol free. So it's just a question, it sounds like you've been doing some work on that. So it was a question around that, and then I've got two other questions. One's a very simple one. The government recently made some money available for drug and alcohol services, and I'm just wondering whether you've bid for that, any of that money, and what you've bid for, if you have. And then finally, I think joint commissioning is most certainly the way forward in this area, and just any thoughts you had on what sort of model would look right? Are there moves towards that at the moment? So sorry, 3 questions there for you, Jane.
Okay, thank you, Kate. Okay, so on the first question, in terms of the those barriers that you talk about, that is the whole purpose of the piece of work we're doing around the task and finish group, is to try and get around those barriers currently. So I think it's fair to say, as I said in the presentation, we it doesn't always act as a barrier, but I think it's sometimes about the practitioners, or that's how it feels from my perspective. So it's not systematic. So we are working with Midlands Partnership and with our colleagues from the mental health element of adult social care to get that systematic approach and try and stop those barriers and that sort of bounce, because what we do know is that obviously, if somebody's got a mental health need, it's not that easy just to stop drinking or stop taking drugs. So we actually need to be working together and working on their mental health needs and their substance misuse needs together. So that's that piece of work. I'm going to forget all your questions now. So the second question, Kate, was around the additional funding that's been made available. So there was basically 2 key elements to that additional funding that's been made available. One was to reduce drug-related deaths, and the other was around the criminal justice agenda. It's only 1 year's funding at the moment. So of course, although we would like to do lots of, start new projects and look at complexity, what we've done is we've tried to add to improve what we've currently got around the criminal justice pathway, particularly looking at those that are coming out of prison and continuity of care from prison, to ensure, and obviously, as you can appreciate, some of the people that will be leaving prison will have the mental health needs as well. And we've also identified women as an area where perhaps we need to strengthen the pathway. So we were also looking to add to our residential rehab programme, working with Willardine Farm in terms of that, with women that are either potentially have got mental health needs, in terms of reducing drug related deaths, or also or sort of on the criminal justice pathway. So I mean, we're doing lots of other things as well in terms of harm reduction and looking at that, but as I say, there was 2 key areas that we were expected to address really, and some of that's around that would be easy nationally to measure if we were doing certain things. So they provided us with a very nice script of interventions that they suggested that perhaps we should fund. So that's where we were. And then the third question was around the joint commissioning, I think, wasn't it? So I know that within the local authority, I've just been invited to a joint commissioning group. I don't believe it's had its first meeting yet. I mean, from my perspective, commissioning drug and alcohol treatments in the past, I've always tried to use a partnership approach, but I will put my hand up now and say probably I've perhaps been a bit neglectful sometimes, although I've had CCG representation, perhaps not always had a mental health commissioner involved in that, and so obviously that's a gap, but I do agree it is the way forward. And in terms of models, I think that needs to be determined locally. There's lots of there's lots of guidance about what a good system looks like, and I think that would be something we would need to look at where it works well and what models work well, really. Okay, thank you.
And I think it's worth just adding, sorry, very quickly, Jane and I now actually work in the same team, Kate, so in terms of bringing from a local authority perspective, commissioning together, we're absolutely doing that, so we work more closely together now.
Thank you. I'd just like to come in and actually just offer apologies, really, and that is to our external contributors who are here from the Midlands Partnership Foundation Trust, those being Kathy and Paul Bowers, and also Colin Evans from the Clinical Commissioning Group, who have been part of this this meeting. But I do feel that maybe our approach and the way the presentations have been made have not been particularly inclusive of their participation. So first of all, I'd just like to apologise that they've given up 2 hours of their time, and really I don't know that they felt that they could participate in this meeting. That maybe this was has been set up wrongly. But before I know we're running over time now. But is there anything that any of those people would like to add and just contribute? I mean, some of the questions that we could have had lined up but have not had the opportunity to really ask is around the funding, and actually how are the decisions made between the local authority and the clinic and the CCG around funding for individuals. It can be quite a protracted system. I don't know if you would agree with that or not. And is there a way that it could be streamlined? I would be interested just to hear, from their perspective, could this process be streamlined? And is there a case for pool funding to facilitate joint decision making? I mean, there's all these sort of areas that I think we could have explored in more detail had we had time, bearing in mind that this new way of working, half an hour is taken up with ruddy housekeeping, excuse my language in that, but just going through this format that we have of having to read all of this gumph out at the very beginning takes up 20 minutes or so, but that's a particular rant of mine. Kathy, you've just come in and said you found it interesting to hear, particularly on supported housing.
I'm in difficulty getting the mute off there, Karen. Just I particularly found it very interesting around the supported housing, because one of the things we're looking at is with CCG commissioning intentions is to review the rehab pathway. And I just thought it was really interesting, Michelle's presentation around supported housing and how we need to link those, because they're obviously different parts of the pathway. But I just think it's absolutely essential that we look at that in a bit more detail.
And I am involved in that work, Kathy. I'm on the working group for that. And just to make it clear, sorry, the CCG have been heavily involved in a lot of what I presented on, particularly around the commissioning of the care and support. And, I present regularly around the accommodation needs now as well, because we do link in a lot more, don't we, Kathy?
And I think it's absolutely essential, actually, Michelle, that we're doing that. And I think it make it much better for some of our patients with complex mental health needs who've traditionally been sent out of area, that if we sort of improve that pathway together, we can actually bring them back into area and reconnect them with family support. So I think that's a really exciting piece of work.
Thank you. I think it was just sort of to get it out there. We had invited you along, and yet I didn't feel as though you've been able to participate. If you're learning something, that is absolutely brilliant. That's what all this process is about, isn't it? About working together. I mean, I've had conversations with Michelle and Yvonne, and I do know that this work is going on in the background, but it's just nice to feel that actually, and for other members to understand that there is this cooperation that is now going on.
Karen, can I just respond to your query around funding?
Yes, please. I was about to pick up on that. You'd come in on chat on that. Thank you, Yvonne.
Just to say that we do now have a funding panel that meets on a fortnightly basis. It's chaired by myself and Colin. and where that panel, it looks at the very complex end of where support is needed. So it's a joint funding arrangement. If somebody is in hospital and need to be discharged on a 117, there's a joint statutory responsibility between the local authority and the CCG, and we do meet on a fortnightly basis. So the barrier is not there anymore in terms of the frequency, and even though we are meeting on a fortnightly basis, if we become aware of somebody who's medically fit for discharge in hospital and need to be discharged, we will have the conversation outside the panel to ensure that there's no barriers.
Thank you. That's excellent to hear. Tanya, you wanted to come in.
Just a comment, Chair. So mental health is a massive subject area. I think it'd be fair to say we could have a whole committee just to discuss mental health, if not 3. So I think today we've kind of focused on commissioning and the CRP work, but I think a future committee may want to have a dedicated committee just looking at some specific areas around mental health, maybe looking at how we support people in terms of prevention, hospital discharge, a number of areas we could focus on. So maybe we could have a conversation as committee in terms of being more targeted next time round in terms of that next subject area. But it's a massive subject, and just to reassure committee, we do very much work in collaboration with both the CCG and MPFT, and we will continue to do so and bring back further papers and conversations for HOSC.
Yeah, absolutely agree with you on that, Tanya. I'm always a great believer in quality, not quantity. And, you know, with both of these items that we've had on the agenda, both of them actually deserved, you know, greater attention, if you like, you know, to fully understand. Now, that might be something you want to take forward into the next municipal administration period, about actually the frequency of scrutiny, because I do think it's better to have maybe more frequent, but actually more focused meetings, rather than trying every 6 or 8 weeks to get as much on the agenda as we possibly can. So I think the frequency maybe of the meeting should be looked at, again, to get that quality of overview and scrutiny on these really interesting and important areas. I mean, there have been quite a few that have been thrown up today, you know, around domestic violence. This is another area that really needs to come back. I don't know, is it PC to say domestic violence now, or is it domestic abuse? I'm not quite sure, but anyway, yeah, it's a really important point. And if there is legislation coming forward that implies a greater delivery of services for local authority, we need to know about them and understand them. I don't know if there's anybody else has any more questions to ask of the officers that are attending this meeting. Have I missed anybody out on the chat? Don't think so. No, I can't see. Yes, I've just picked up a message from Paul Bowers saying, hi, as per Kathy's comments, the presentations, particularly Yvonne Michelle's, have been useful to hear, and I have ideas of how we can better link up. So I'm glad to hear that there is something positive for our external members that have given up 2 hours of their day to participate in this meeting. So I'm not seeing anybody. Oh, no, somebody's just said they've got to go. So can we make sure that all of these slides go out to all of the members, because there was an awful lot of information in the slides. Can we make sure those go out to members sooner rather than later, actually, not just attached to the minutes? I think that would be very, very helpful. And so on that note, I would just again like to thank everybody for attending. Oh, wait a minute, I've just got one here from Heather. Heather, would you like to ask this question?
No, what I was really saying, I was really pleased to hear, and I did ask to speak earlier, but that actually we're beginning to integrate drugs and alcohol and mental health, because as soon as somebody started self-medicating in some way or another, they were then put into that rather than looking at the underlying reasons. So it's a really good step forward, but that future work really needs to look at how that goes forward. So it does really need to be built in.
Yeah, thank you for that supportive comment, Heather. I have just got one. I've just looked at my list of notes and what have you. I've just got one very, very quick question for Jane, and that is why there is such a low number of IAPT patients with drug and alcohol or substance misuse. Why is there such a low number on that? I think it was the previous slide that you had. Why is there such a low number of IAPT? Is that around capacity, funding, commissioning?
It's not around capacity. It's around the fact that they can't, and this is a national issue. They're not allowed to take people that are actually under the influence or are using substances at the time. So it just means that there's quite a lot of people that are excluded, but it's a national problem. It's within their framework, if you like. So
well, that just seems sort of rather bonkers, and goes back to what Heather was saying. You know, this is one of the main tools we have at our disposal, and yet we're discriminating and alienating a large proportion of our people who actually need the services. Is it being addressed nationally?
It certainly has been raised at the regional level. I haven't got an updated picture on it, but I know certainly it has been raised. So, you know, from my colleagues regionally, they do pass things up to the centre. So I can always update you in the future.
I think the drum needs to be beat quite loudly on this one because, you know, as I say, I mean, there was a paper a few years ago, wasn't there, about the success of IAPT, and it wasn't terribly complimentary. And you would hope that they were looking at ways of actually improving the outcomes of people accessing that particular IAPT and the tool that it is. Heather, you've just put your hand up, I see.
Yes, I did, and I mean, this is really one of the things I've come across, in that if you have somebody who's self-medicated because they've been seriously mentally ill, then the ambulance service won't take them away. And I know personally of a family with a 2-year-old who were left with a totally demented adult in the house because the ambulance service would not remove them, because he'd self-medicated. This is a safeguarding issue. So we really do need to put real pressure on the government to actually change this and find a way through it, because somebody who is suffering mentally and has subsequently been diagnosed as bipolar should not be put in a position where the rest of the family is seriously affected by a mental health issue.
Well, thank you for highlighting that, Heather, and Jane, thank you. I'm glad I asked that question. You know, to highlight.
Sorry, I was just going to add though, just in terms of my position within adult social care. So I do work very well. Jonathan Allen is part of the team. So although the numbers look very low, we are looking at ways and communicating and making sure that if there are people that are able to access the service, that that they can do that. And I think it's also to note that that's where people are when they enter the service. So that's when they first come into our treatment service. So potentially those numbers would go up, but not by a lot. I think that's the issue. So.
Okay, so thank you very much, everybody, for attending. Thank you for your contributions. And I say this is my last meeting as chair. I'd just like to thank all of the officers present for your contributions, your support throughout the years. Your dedication is second to none. And I mentioned earlier on, your compassion that is shown throughout your work is something that I'm very, very proud of. Sometimes I think that some of the decisions we take as members don't make life easy for you. But you always fulfill your roles with good grace. So and such, your experience is invaluable, and your support. I'm blethering now, so I'm going to shut up and say thank you very much to everybody. Good luck for the future. And I also just want to make one specific thank you, and that is to Daniel Webb and to Amanda Hollyoak for their unswavering support over the years. And I would be absolutely lost without them. So thank you very, very much to everybody. And so 10 minutes, 16 minutes overdue. welcome, goodbye everybody, and good luck for the future.
Karen.